Picture this. It is Tuesday morning clinic. Your next patient is 68, a 30-pack year smoker, COPD for a decade. She is here with increased sputum, more breathlessness, and a cough that woke her up 3 nights running. Classic acute exacerbation. Do you reach for the amoxicillin or do you reach for a CRP test?
And that question matters more than people think, because most COPD exacerbations are viral, but antibiotics are prescribed in 60 to 80% of COPD exacerbations in primary care. That is a massive driver of resistance, C. diff, and patient harm from drugs that were never going to help.
A new meta-analysis published in the British Journal of General Practice this month gives us the clearest answer yet. It pooled 5 studies with over 2,500 patients, all in primary care, all looking at whether a CRP point-of-care test could safely reduce antibiotic prescribing for COPD exacerbations.
And the result was striking. Not just statistically significant, but clinically large. Let me guess the effect size.
The pooled odds ratio was 0.41. In plain English, patients who had a CRP test were about 60% less likely to receive an antibiotic. And critically, there was no evidence of harm, no increase in hospitalizations, no increase in treatment failures, no excess mortality.
60%, that is enormous for a stewardship intervention, but I need to push on this. Most of the studies in this meta-analysis were observational, not randomized. Only one was an RCT. How much should we trust a pooled estimate when 4 or 5 studies are non-randomized?
Fair point. The authors graded the certainty of evidence as low to moderate, but the sensitivity analysis looking only at the 3 best quality studies gave an odds ratio of 0.37, even tighter, and the single RCT, which had 653 patients, showed the same signal. The direction is consistent across every study.
Okay, that is more reassuring. So what are the actual thresholds? Where do you draw the line?
The best quality study used a CRP of 40 as the cutoff. Below 40, do not prescribe. Above 100, prescribe. Between 40 and 100, use clinical judgment, weighting sputum purulence heavily. This is directly actionable. You can buy a CRP point-of-care device for a few $1,000s. Each test costs about $5 to $8, and it changes your prescribing on the spot.
And this connects to what NPS Medicine-wise has been pushing for years. Stewardship is not just about choosing the right drug. It is about deciding whether a drug is needed at all. CRP testing is the tool that makes that decision evidence-based rather than gut feeling.
A practical takeaway. Next time you see a COPD exacerbation in primary care, ask yourself whether a CRP would change your management. If the answer is yes, do the test. If the CRP is under 40, explain to the patient that this is likely viral, prescribe steroids and a bronchodilator, and hold the antibiotic. That conversation is backed by evidence.
All right, let us move to story 2. This one involves a drug that nearly every GP in Australia is prescribing, oral semaglutide.
Oral semaglutide, brand name Rybelsus, was the first oral GLP-1 receptor agonist. It has been PBS listed for type 2 diabetes since 2020. The sole trial was its cardiovascular outcome trial. Nearly 10,000 patients with type 2 diabetes and established cardiovascular disease or chronic kidney disease. It showed a 14% reduction in major adverse cardiovascular events. We covered the primary results before.
But what is new is a secondary analysis of SOUL looking specifically at heart failure outcomes, published in JAMA Internal Medicine earlier this year. And this is where it gets really interesting for primary care.
About 23% of SOUL participants had a history of heart failure at baseline. Just over 1,000 of those had preserved ejection fraction. In those heart failure patients, oral semaglutide reduced the composite of heart failure hospitalization, urgent heart failure visit, or cardiovascular death by 22%. Hazard ratio of 0.78.
22%. But let me be specific about the subgroup signal. The benefit was driven almost entirely by patients with preserved ejection fraction, HFpEF. In that subgroup, the hazard ratio was 0.59, a 41% reduction. In HFpEF, reduced ejection fraction, there was no signal at all. Hazard ratio 0.98.
This matters enormously. HFpEF is the heart failure phenotype we have been losing. We have SGLT2 inhibitors which help modestly, but there is no drug that specifically targets the underlying pathophysiology. And HFpEF is the heart failure of obesity, diabetes, and metabolic syndrome. Exactly the patients on GLP-1 receptor agonists.
There is a biological plausibility here. GLP-1 receptors exist in the myocardium and vasculature. Semaglutide reduces inflammation, improves endothelial function, and produces weight loss. All of these are relevant to HFpEF, which is fundamentally a disease of diastolic dysfunction driven by remodeling and increased filling pressures.
Now the caveats. This is a secondary analysis, not a pre-specified primary endpoint. The p-value for interaction between heart failure and no heart failure subgroups was 0.06. It did not quite reach conventional significance, and there was no echo data to track ejection fraction changes over time.
So it is hypothesis generating, but it is a strong hypothesis, and it comes on top of the STEP HFpEF trial, which showed that injectable semaglutide improved symptoms and exercise function in patients with obesity-related HFpEF, even without diabetes. The signal is converging.
For your practice, the takeaway is this. If you have a patient with type 2 diabetes and HFpEF, oral semaglutide is not just a glucose-lowering agent, it may be providing cardiovascular and heart failure protection, and since it is already PBS listed for type 2 diabetes, you do not need to wait for a new indication. The evidence is already there.
Agreed. Now, story 3. Something for your wife. Labor induction.
Labor induction is one of the most common interventions in obstetrics. About a third of all births in Australia involve induction, and the question of which agent to use has been debated for decades. A new meta-analysis published in the Journal of Obstetrics and Gynecology Research this month compared 2 of the most common agents, oral misoprostol versus vaginal dinoprostone.
This is a genuinely important question. The Cochrane Network meta-analysis we covered back in episode 7 found that no method was superior to low-dose vaginal misoprostol for effectiveness, but oral misoprostol is cheaper, does not require refrigeration, and is more acceptable to patients. The question is whether it is actually as good.
This meta-analysis pooled 11 RCTs with nearly 3,800 participants, all singleton pregnancies at 34 weeks or beyond, and the headline finding was clear. Oral misoprostol was associated with a 17% lower rate of caesarean birth compared to vaginal dinoprostone, 19% versus 24%.
Lower caesarean rate. That is a hard endpoint that matters to patients and obstetricians, but there is always a trade-off. Dinoprostone was faster, higher rate of vaginal birth within 24 hours, 58% versus 53%, and a shorter induction to birth interval by about 2.5 hours.
Exactly. So the trade-off trade-off is this: oral misoprostol gives you fewer caesareans but a slightly longer labor. Vaginal dinoprostone gets you a faster delivery but with more caesareans. And the safety profile was comparable. No significant difference in uterine hyperstimulation, low AGOS scores, or NICU admission.
Let me interrogate this a bit more. The caesarean rate difference is interesting, but is it clinically meaningful or just statistically significant? The absolute difference is about 4 to 5 percentage points. For every 20 to 25 women induced, one fewer caesarean. That is not trivial.
And there was less need for oxytocin augmentation with oral misoprostol as well. 34% versus 37%, which makes sense mechanistically. Misoprostol is a prostaglandin E1 analog that both ripens the cervix and stimulates uterine contractions. Dinoprostone, a prostaglandin E2, primarily ripens the cervix but may be less effective at maintaining contraction patterns, hence more need for oxytocin.
There is a practical angle here for rural and remote practice. Oral misoprostol is cheap, stable at room temperature, and does not require the cold chain that vaginal prostaglandins need. For a rural birthing unit, that matters. And the WHO has already recommended oral misoprostol as a first-line agent for induction in low-resource settings.
Tell your wife about this one. The choice of induction agent is often driven by local protocol and clinician habit. This meta-analysis gives you evidence to support a discussion about oral misoprostol as a reasonable first choice, particularly if the priority is avoiding caesarean.
Now, story 4. This one is about sepsis, and it changes how we think about antibiotic timing.
The Surviving Sepsis campaign guidelines say antibiotics within 1 hour for patients in shock, within 3 hours for possible sepsis without shock. But here is the problem. How do you identify who is actually at risk of dying from a delay? Shock is obvious, but many patients with serious infection do not present in shock.
A massive study published in the Lancet Respiratory Medicine on August 5th looked at this. Nearly 100,000 encounters across 9 hospitals in the Mass General Brigham system in the U.S. They compared 2 strategies for stratifying antibiotic urgency: shock status, which is the current guideline approach, versus never use 2 score, which is the UK National Early Warning Score.
And the finding was striking. In patients with shock, each additional hour to antibiotics increased mortality by 1.5%. That confirms what we already know, but in patients with a never use 2 score of 7 or higher, even without shock, each hour delay increased mortality by about 0.5%.
And how many of those high never use 2 patients did not have shock?
86%. Of the 26,000 encounters with a never use 2 of 7 or higher, 22,000 had no shock. And in those patients, antibiotic delay was still associated with increased mortality. Below a never use 2 of 7, there was no association between delay and death.
That is a meaningful shift. It says that using shock alone to determine who gets antibiotics within 1 hour misses a large number of patients who are also at risk from delays. Never use 2 captures them. It includes factors like respiratory rate, oxygen saturation, temperature, blood pressure, heart rate, and consciousness. And it can be upgraded with lab values like lactate and neutrophil count.
For your rural ED, this matters. You may not always have an intensivist or a sepsis team, but you can calculate a never use 2 score at triage. And if it is 7 or above, that patient needs antibiotics within the hour, regardless of whether their blood pressure has crashed. Do not wait for shock to develop.
The practical implementation is straightforward. Build never use 2 into your triage workflow. Use the lab upgraded version where you factor in lactate and new organ dysfunction within 3 hours of arrival. And treat a never use 2 of 7 as a 1-hour antibiotic trigger, not a 3-hour trigger.
Quick hits before we wrap. 3 items.
First, a new herpes zoster vaccine called LZ901 reported phase 3 results this week in Nature Communications. 26,000 adults aged 40 and older, 92% efficacy against shingles, 96% against post-herpetic neuralgia. It uses an aluminium adjuvant rather than the AS01B adjuvant in Shingrix, which may mean fewer reactogenicity issues. It is approved in China but not yet in Australia. File this one for when it arrives.
Second, PBS brand deletions on September 1st. Amoxil capsules Cardizem CD, Actos, and Polyvisc are being removed. Generics remain available. Check your repeats and transition patients to remaining brands before the changeover.
Third, tafoxiparin, a novel non-anticoagulant heparin derivative, showed promising phase 2 results for cervical ripening and labor induction this month. Published in Acta Obstetricia et Gynecologica Scandinavica. 348 nulliparous women. The 300 mg dose increased cervical ripening, increased spontaneous onset of labor, and reduced instrumental vaginal delivery rates. Phase 3 trials are needed. This is a new mechanism of action, worth watching for your wife's field.
Let us recap. 4 stories today.
1. CRP point-of-care testing for COPD exacerbations. 60% reduction in antibiotic prescribing. Cutoff at 40. No evidence of harm. Use it in primary care.
2. Oral semaglutide in type 2 diabetes with heart failure. 22% reduction in heart failure events overall, driven by a 41% reduction in HFpEF. PBS listed. Already available.
3. Oral misoprostol versus vaginal dinoprostone for labor induction. Oral misoprostol reduces caesarean rates by 17% with comparable safety. Discuss with your obstetrics colleagues.
4. NINUS 2 score of 7 or higher identifies patients at risk from antibiotic delays even without shock. Build it into triage. Treat high NINUS 2 as a 1-hour antibiotic trigger.
See you tomorrow. Stay sharp.